Good afternoon, everybody, and a very warm welcome to this section where we're going to be focusing on paediatrics, so young people, and we've got a great lineup of speakers. We're going to be beginning with inviting Claudia Linda up to talk to us, I think, on some very interesting topics, particularly related to the use of AI in radiographic work in hips, in cerebral palsy. Yep. And then you've also, well, I think you've got an extended presentation. So I'll let you come up and introduce yourself. So, and at the end of your talk, we'll take some questions, and that will then be followed by 3 further presentations.
Well, thank you for the introduction. So my name is Claudia Linton. I'm a Senior Research Fellow and Serenity Fellow at the University of Manchester. And so, as was just alluded to, it's actually 2 abstracts I'm going to talk about, but because that's quite a mouthful, I thought I'm kind of just put it into one. So I'm going to talk about automatic measurements on hip radiographs in children with cerebral palsy. So this little boy here, he's got cerebral palsy. And cerebral palsy is the most common physical disability in children, with about 1 in 400 babies born affected. And having cerebral palsy, it means that this little boy will have all kinds of health implications. One of which being is that he's got a high risk that his hips will dislocate. Now, if his hip is dislocating, it means he will have severe pain, he will have problems sitting, and he will also need quite complex invasive surgery. So what happens when the hip dislocates is basically the hip bone is moving out of its socket. And that's because abnormal massive forces kind of keep pulling on that bone, and eventually, unfortunately, some children, it moves out, and this is when the doctors need to do that quite complex surgery to get it back in. Now, if the doctors were able to spot that the hip is on its way out, then they can do a lot less invasive, less costly, less complex surgery. And so this is where our work is focusing on. So we want to enable that every child with cerebral palsy gets monitored appropriately for hip migration, so that the doctors can intervene early enough with the appropriate treatment. And actually, the National Institute for Health and Care Excellence is recommending that these children are regularly monitored for hip migration. So they have regular X-ray images taken. And in these images, doctors need to assess how far the hip bone might have already moved out, and whether it's moving out quickly or whether it's quite stable. And these measurements are really important because it's the measurements that then tell the doctors on how much change has happened compared to last time, and how quickly might this hip bone moving out. And so this monitoring of those children with cerebral palsy is happening as part of a national surveillance program, which is called the Cerebral Palsy Integrated Pathway, or CPIPS. And in areas where it's implemented well, this is really successful, and it helps improving the outcomes for those children. But unfortunately, in quite a few areas, there is a lack of resources for doing that. And because it's quite time consuming, because currently the images need to be measured manually. Depending on the trust and the IT infrastructure, it might be easier or more difficult. And also the quality of those measurements depend on who's actually taking the measurements. And so in some areas, there might be months between the image being taken and the image actually being measured. And so that means that across the country, there's quite an inequality in care in terms of how good the care of a child with cerebral palsy is. And so we are proposing an AI-based system to automatically measure these images. And so our system is based on outlining the structures of interest with a number of point positions, which I hope you can see in green over here. And then we use those point positions to define clinically relevant measurement. So one of which is the Reinhardt migration percentage, which is the key measurement to assess hip migration in those children's hips. But we also look at other measurements which might be relevant, such as neck shaft angle and hip shaft angle. And so the way it works from a technological point of view, so I'm not going into too much detail, but as I said, it's a machine learning approach. And so it learns from training data, and it learns to find that hip joint in the images. So it kind of learns where in the image is that hip joint, and then it goes down in a lot more detailed level, and each of our little points will look at where that little point should be based. So our points have got a unique ID, so that we can then use those points to define the measurement, and so that we can consistently take those measurements across different images. And so the way it comes all together in terms of a system is that you've got an image that the system has never seen before. You feed it into our tool. It will then automatically place those point positions around the key structures that we've identified for this application. And then based on the point positions, it will generate those measurements. Now, we validated our system on a large clinical data set of hip radiographs of 1,650 children with cerebral palsy. And the way we've assessed the performance is by comparing our automatic measurements with that of 5 clinical experts who've also measured the same images. And for neck shaft angle and ramus migration percentage, we had manual measurements available for all 3,300 hips. For head shaft angles, because that kind of joined in later, we only had manual measurements for about 900 of the hips. Now, in terms of results, what we found that there was good agreement within the clinical experts, as well as between the expert and the automatic system to take the measurement, and there was moderate agreement for head shaft angle. For ramus migration percentage, which is the key measurement to assess hip migration in children, we found excellent agreement within the clinical experts, but also between the manual clinical expert measurements and the automated measurements. And actually, when we looked at the mean absolute difference between the automatic and the manual measurements for ramus migration percentage, we found that that was in the range of what would be expected if we were to ask a clinical expert to measure the same image twice. And so in conclusion, our system performs equally well to assess hip migration based on ramus migration percentage as the clinical expert that we used in our validation study. We also looked into the utility of the technology to support decision-making in the monitoring of patients with hip migration. And we did this by looking at the diagnostic consistency between using the automatic measurements and using the manual measurements for 3 thresholds of ramus migration percentage. For if the ramus migration percentage was larger than 30 degrees, which indicates the referral to the orthopedic department, larger than 40%, which might mean to consider a surgical intervention, and then identifying hips with a ramus migration percentage larger than 50%, which has recently been identified as a point of no return, which means that if a hip has migrated that much, then it won't go back to normal without surgical intervention. And so what we found in terms of results, that there was high diagnostic consistency for all of these 3 thresholds, but in particular with regards to those hips that definitely require surgical intervention. Okay, so we've got a system to automatically measure hip migration in this image. Why? Why is it important? What is it good for? And so to better understand the current situation and the clinical need for such an automated system, we conducted an electronic survey that we sent out to the Association of Pediatric Chartered Physiotherapists, to the British Society of Pediatric Cardiology, and also to the Association of Pediatric Radiographers. And in total, the survey was fully completed by 114 respondents, where 103 of them were physiotherapists, 6 were pediatric orthopedic surgeons, 4 were radiologists, and 1 radiographer. Out of the 103 physiotherapists, 15 were reporting that they were actively involved in measuring ramus migration percentage on children with cerebral palsy. And 10 of these 15 reported that it takes them more than 5 minutes to measure a single image. And so that doesn't include sending that data onto the CPIP database, so that's just the measurement. And so we were then interested in, okay, if that's just a measurement, how long does it take currently to measure the image, but then also report that information as part of the CPIPs program? And here we found that it takes at least 5 minutes, and for more than a third of respondents said it will actually take them longer than 10 minutes to kind of go through that whole process. Now, previous to this survey that we sent out, we had previously sent a similar survey out to pediatric orthopedic surgeons, and they report that they're a bit faster in kind of doing that whole process. But nevertheless, for the majority of images, they still say it takes more than 5 minutes doing this, and there's a significant number of images where they as well agree that it takes more than 10 minutes to go through that whole kind of process. Now, linking that time aspect to our system, we then were asking people, well, if there was an automatic system in place to do that, would you use it? And so here we've seen really quite a lot of enthusiasm, both amongst physiotherapists as well as amongst the surgeons, with 80 to 90% saying, yes, we would use it. And no one said, no, we wouldn't use it. There were a few that said, maybe. But yeah, it's really quite promising that there seems to be a large opportunity for automating this process as part of the clinical care pathway for those children. We also wanted to explore what the perceived benefit of such a system was. So we asked people about why would you use it? What would you think is the benefit of it? And in terms of results, some of the results is what we would expect it. It's why we're doing this work based on the input from our clinical collaborators. Other results were, I guess we were surprised by those. So the ones we kind of expected to hear is that it will save clinicians time, it will increase consistency, it will reduce delays, and it will also potentially improve patient outcomes. Now, the ones we're a bit surprised about are these two. The first one is that people say that actually, it might increase accuracy. So we kind of also want to be as good as the manual measurements, but they actually say, oh no, your automatic system will be better as the manual measurements. And when we question that, we found that there are people in the clinical community that say they don't feel well enough trained to take these measurements. So they think, oh, actually an automatic system will be better than what we are currently doing. And then the second bit we were surprised about is that people were saying, well, depending on how the setup is for the whole pathway for measuring and reporting those values, that some people in the clinical care team might not have access to the images, might not have access to the data in time. So if we were to integrate all the information in an automated fashion, then everyone could see all the data. So everyone in the clinical care team would be equally informed to look after these children. And so the last question to report on today that we included in our survey is this one, where we asked people, okay, so what can we do? If we develop such a system, what can we do to actually improve clinical acceptance? And so the response to that was twofold. So some people talked more about barriers and some people talked about enablers. So in terms of barriers, we heard a lot about costs. So that's a kind of affordable to implement the system. But then also people were concerned about the often outdated IT systems in the NHS and saying, oh, can you actually make it work with what is currently there? So these are the main two barriers that came out. In terms of enablers, the most dominant one was around education. And it wasn't just about education, how to use it, but actually how does it work? So people said, we want to know how does it work? How actually does it do the measurements to feel more confident in actually trusting the results? And the second bit was about evidence, specifically about providing evidence across different trusts that it's working and not just a single source of data. And so where are we going with this? What's next for us? So currently we have started to validating the system on additional data sets in additional trusts, not just because that's what obviously the potential users in the future want, but also that this data that we need to get the technology regulated as a medical device. But overall, so our ultimate goal really is to fully integrate the system into the CPAP pathway. So whenever there's a hip X-ray taken for a child with cerebral palsy, that would be automatically sent to our system. It would do all the point placements and all of that, generate the measurements, and then the measurements will be sent back to the trust. So that the trust, you've got the images and you've got the measurements, and that will then go into the electronic health record for the patient to inform the clinical care for the patient. But it would also go into the CPIP system to create the potentially largest database of measurements for children's hips with cerebral palsy, enabling important future research in that direction of how can we better serve these patients. Now, to go down there, something I already alluded to is we need regulatory approval, and so that our kind of immediate next step to get the system regulated as a medical device so that we can start integrating that system in clinical environments. And so in conclusion, our system will help spot which children with cerebral palsy might have hip problems to enable less invasive, less complex and less costly intervention. It will save doctors about 10 minutes analysis time, and it will also reduce measurement inconsistency by automating the process. And overall, by addressing resource gaps and resource allocation, it will facilitate the care for these children and hopefully enable equal care for those children across the country and beyond. I'd like to thank all my collaborators, co-authors and funders, and thank you for listening. I'm happy to take any questions.
Thank you very much for a fascinating presentation. Amazing to be in the world that they are now, where we're going. It sounds like really amazing innovation. Do we have any questions? Any questions? 1, 2, is that 1? 3, lovely. If you'd like to just say who you are and then ask a question.
Okay, thank you. Kath Brimlow, I'm from Craig Halbert Centre in Scotland, so a paediatric physio. In our school, only a quarter of our children are cerebral palsy, and the rest are complex children and non-ambulatory. And we still do all the CPIPs measurements for them. And at another conference, which is a medical conference, we were talking about rolling that out to these other children with complex needs. But the doctors were concerned that with limited resources, that wouldn't be possible. But I'm just wondering if you see this in the future as rolling out to all the children who are non-ambulant and at risk of hip dysplasia.
Yeah, so it's actually something I've heard before from a different trust who said, "Oh no, we're measuring all the children, but that might be an issue." And I think from the technology point of view, that's not a problem at all, because it's kind of the same thing. It's a hip of a child to kind of and measure it. It's more probably one would need to establish the pathway. So it sounds like where you are, that pathway is there, and once it's implemented, you just do it, and it's fine. But from what I know, there will be other trusts where those children are not currently measured. So I think there will be a lot more work around how do we get the system, the pathway into place so that those children in those areas benefit as well. But maybe I think I quite like the argument that you're making. Well, actually, if you've got an automatic system, it doesn't put that much additional pressure on the system. So why not? So yeah, it'd be great to include additional diseases in that as well.
Lovely, thanks very much. Another question?
Is this? Yeah, it's working. Erin Hannock. I am a research physio from Oxford Hospitals University Trust. My question is more around the AI and the learning process. So I think you mentioned 1600 that it's learned on. I can imagine it's kind of a steep learning curve, and then it kind of plateaus. And is that how it works? Is it will it plateau after a certain number that it's learned from, and what number would you expect kind of that to be in?
Right, there's a couple of things in there. The first one is it's not been trained on the 1600, so the 1600 were to kind of assess the system. So depending on how much knowledge you've got about AI, so we use something that's called cross-validation. So to maximize the data usage, so obviously a bad thing in AI is that people need to be taken care of, I suppose, is you don't want to develop a system on the same data as where you test it. Unfortunately, it still happens, but it's really, really bad. Because yes, your system will be great because it's seen all this data before, so it'll be really good at doing it. So it's a big no-no. So you need to have a separate data to train your system, and then you take another data set where you want to test it on. Now, if you've got a limited amount of data, people apply something that's called cross-validation. So basically, they split the data. So the simplest part way is twofold, what's called twofold cross-validation. So let's say you've got 1,000 images, so you've got 500 and 500. You train it on those 500, and then you test it on those 500. Then you train it on those 500, and you test it on those 500. So this way, you still can provide evidence on all 1,000 images, but you don't have the problem saying, oh, we trained and tested on the same image. And so we didn't use the whole data to train the system. We used cross-validation. There is so we're not using deep learning. We're using random forests. And so what we found across different parts of the body is actually quite small data sets work quite well. So we only need a few hundred, and it's working really well. I do agree. There's a small increase the more you add. But I think the biggest benefit, I guess, from extending the data will be one around including additional variation. So currently we've not included images where the hip would have a replacement in. So again, so you would want to expand. It's still working quite well for some of the images, but we've not trained it on. But going forward, you would want to include those images in the training. So that's the reason why you would boost it. Or if you do encounter, I don't know, that a different X-ray machine, the images look really, really different from the resolution, then again, you would include some of those images for the training data to have seen those kind of images. So it always depends on the data, on what the number is. But yeah, there's
Fascinating
certainly
learning
training.
machine. Sounds like a fascinating learning machine. Thanks so much for that. Really great answer as well. Great question. Okay, I think one more. Yep, we've got time.
Love these. I'm Anna. I'm a pediatric physiotherapist by background, also chair of APCP here. Great work, great presentation. Thank you so much. And I'm sure you will be able to talk about it all day if you could. So that might be my reflection or comment, might not be one that actually is driven, but you mentioned decision making based on that system and that delivery. I'm wondering, how do you envisage implementing this in practice? Because the decision making about children's hips is so complex and it's driven by a multitude of factors, including surgeons' philosophy of practice, evidence that can be sometimes contradictive still, and the context of child's life. How does the AI sit with that complexity?
Fully agree with your comment. And we don't do decision making. So kind of what I presented was just to see if we were to rely on the measurements that were generated, just on the measurements, this would be the difference between relying on data that was manually generated by a clinical expert, and this will be what the system does. The clinical decision making we leave to the clinicians. So all we are doing is we can't take away that manual step of measuring the images and then looking into the CPIP system, reporting the data, making sure there's no transcription error, making sure the values are there for every child, making sure the dates are matched, and all of these kind of error sources where currently there might be issues in the CPIP's database. So we are just providing the data, and then the doctors will make the decisions.
Right, man and machine, fantastic. I think we'll leave for questions for now. Is that everyone? I think wonderful presentation. Thank you so much. And we're looking forward to hearing more about this one. I've got two microphones now and I don't know whether they're going to interfere with each other or not. So unfortunately, our next speaker isn't here. So we've got it's allowed us a little more space, which does mean we can have the questions that we need to have. So it's now my huge pleasure to invite Dr. Erin Hannick from the University of Oxford to come and talk to us about adolescent idiopathic scoliosis. So very warm welcome.
Hi, thank you. So today I'm going to talk about the experience of living with adolescent idiopathic scoliosis, and this was done through a qualitative evidence synthesis. So a bit of context, just a reminder, scoliosis is defined by a lateral spinal curvature of at least 10 degrees, and specifically we'll be talking about adolescent idiopathic scoliosis, AIS, which is diagnosed from 10 years old. And of course, it is associated with many different physical and psychosocial implications. And as we're looking at the experiences of adolescents with this, we're going to be exploring that more through this quiz. So our aim was to synthesize all the qualitative research that's published that we found to really explore what it's like to live with this condition. So first of all, we did a systematic search with all the terms around scoliosis and qualitative research. And we included studies published in English. We excluded specifically early onset or adult onset scoliosis and those conditions that cause scoliosis that weren't specifically AIS. And just briefly, we searched 4 databases. We came up with 404 articles, and included were 9 studies that were unique and 10 articles. And to synthesize our data, we went through the 7 stages of meta-ethnography. I'm not going to go into this in detail because I really want to focus on the findings. So of the 114 voices that we included, most of them were female, which we would expect. And we also included the voices of parents. So in one study, we had parents of young women with AIS, and because of this stage in life as an adolescent, we thought this was really important to also look at the parent viewpoint with the adolescent. And through these studies, we got a range of different experience because of the evolution of AIS. Part of it was, we looked at the experience of a physiotherapy intervention, all the way up to wearing a brace, progressing with a brace, and then even to surgery, the decision-making around surgery, the actual lead up to surgery, and the surgery recovery. So of 159 concepts, we distilled it down to 35 categories, and then ultimately 7 themes. And I'm going to go through these one by one, so you don't have to read them here necessarily. So first, diagnosis turned time on its head. So from one young person, they said, it's been a roller coaster ride. I mean, 1 minute I was just healthy, living a good life, and then we found this out, like someone turned sand timer. So, this was, many people expressed shock, both adolescents and parents, and this theme was just the uncertainty about the future. So there was an uncertainty about how they would go through their life, and parents specifically, they express kind of guilt and why didn't I see this sooner? Why didn't I know? The next theme, usual activity is no longer the same. So this explored how activities were impacted or limited or changed or even forgotten because of the new limitations from AIS. And so from one young person, I had to stop training, and when I could take it up again, I felt it felt difficult. The team had grown so much better, and I was left behind. So in this case, it was a big limitation. It was something that they had to let go of. But in other cases, it was a way to cope. It was a way to help them get through and have a support system and have activities and participation to be part of. Hiding my body, and this was a big theme because, again, AIS is a spinal deformity. It can be seen. In the beginning, it's a curvature in your spine, and as it progresses, it causes not invasive, but braces that are really kind of a big part of your life. And then when there's the decision to go into surgery, it's a big major surgery, but also it leaves you, maybe you're straighter, but then you have a visible scar. So this was the challenge with body image and appearance. I want to feel normal again. So this theme was, that was quick. Thank you. This theme was about, feeling normal, but also more feeling different, not having others that were like you or just feeling out like an outsider. Then balancing isolation and support. Again, there was feelings of loneliness, although there were friendships made, but also friendships lost. And especially with this group, there was a lot of support and foundation in the parent relationship. So trying to keep control of treatment decisions. This was underlined by the want for a strong communication with with clinicians, and it wasn't only the young person and the clinician or the parent and the clinician. It was also kind of the communication, the treatment decisions between and the push and pull between the parent and the child. And then lastly, fearing surgery yet feeling hopeful. So this revolved around a big decision and just real fear around the surgery, but it being a marker of hope after this long journey. Usually with surgery, there were years of braces that came before that, and a long process. So it was a optimistic signal of hope. Oh, okay. It was. That's okay. I'll have more time for the conclusions. It's okay. So hopefully, this kind of highlights the profound impact that AIS does have on adolescents, and emphasizes, especially for physios, that the strong communication and shared decision making if we're treating patients with AIS, and this can give us a better understanding and hopefully again influence positive clinical interactions.
Well, lovely, and so very much thank you for that great presentation. Absolutely stunning images in there. I was just envying them, and they really brought them to life, didn't they? Those experiences of young people with scoliosis. So many of us work with young people with scoliosis. So we have got time for some questions, and you may be able to flip back to some of your slides if people want to have a look more at some detail. Have we got any questions?
I know of a high-profile celebrity who has had scoliosis surgery for AIS, and she talks about being disabled. I know, which I find shocking, but anyway, might be my age because I'm getting old. Did you find that with the children and adolescents? Did they feel that they were disabled, or?
I feel it didn't come out of the experiences and the data that we found in the narratives. So, but that absolutely can be how someone feels when you don't feel like you can do the things you used to do. But that didn't really come out with these studies.
I'm interested in the 7 stages of meta-analysis, but
Yeah, take us back
I
to
don't
some
know if
research
other people
evidence.
are, but if other people are, then that's fine. But if not, I'll just have a quiet word afterwards.
Yes, take us through this process, because actually quite a complex process, but fantastic. I think we can all have a learning from that, if you don't mind.
Yeah. So when most I don't know, it depends on what kind of research you're doing. It's when we're looking at qualitative research, we want to first of all get our question, decide what's relevant. So number 2 is deciding what's relevant. So again, really narrowing down. Actually, the origin of this study was to look at the experience of actual sports and activity, but we found that there really wasn't any. So we broadened it to just see what is the experience, and a bit of the activity and a bit of that sport came out in that, but there weren't really studies that were looking just at the sport and activity aspect of it. And then reading the studies, determining how they are related. So looking at them together, kind of pulling out the data and seeing common themes, and that's where kind of the concepts and the subcategories came from, and then translating studies to one another. Again, it's not looking at it's trying to put them all together and not trying to count up the number of times someone said, I don't feel normal. It's just kind of gathering all of the ideas coming from this narrative, and then synthesizing the translations, trying to find more meaning out of the words that we gathered and the themes that we gathered, and then expressing the synthesis. And we went an extra step, and I developed another conceptual model that I don't have here, but we've published, and kind of just relating the push and pull between isolation and support, the decision making, that timer where life is different, and your body and your participation changes. So that's a bit about kind of the steps of a meta-ethnography.
Lovely, very interpretive approach, and wonderful. Thank you so much for taking us through that. Anyone else got any questions? Yeah, and if you just want to introduce yourself.
Catch. Hi, I'm Rachel. I'm a paediatric physio down in Devon, and I wondered whether, because you're quite a big age range within your population that were sharing their views, I wondered whether there was any contradictions or differences within some of those themes, when we're thinking about implementing some of these findings and how it impacts on our practice. Did you find differences between younger or older, girls, boys? Was there any demographics that stood out for you that changed some of the views?
Because there were only 9 studies, and the way we did it, I didn't pull out specific. I'm purposely tried to look at it all without seeing the differences in where the narrative was coming from. But one area that I thought was interesting in terms of the stages they were at was the stages and severity of where they were at, because again, just being diagnosed and having a moderate or mild curvature and having physiotherapy was different than having progressive braces and then all the way to the stage of surgery. But the approach we took, we weren't able to kind of pull that out because it would be, the evidence would be thin in a way. But all interesting things that popped into my mind thinking, are the boys saying something different? And actually, I would like to just interview boys to see that experience. And that would be, I think, the next step. That would be great research to do, is look at just the adolescent boys.
And up the back there, Christine.
I was really interested in your element of involving the parent view, and I think this, as paediatric physiotherapists, obviously we have to be just as skilled, really, don't we, with dealing with children and their parents. And I'm just really struck by how shocked parents would be with this condition when they see their child undressed. And this age range is often an age where they stop seeing their own child. So I think as therapists, that's a really good point, isn't it, to highlight that the parents need support at that stage of diagnosis when they're in absolute shock and guilt and blame, and to help them move forward to support their child. So I thought that was really interesting.
It's great that you bring up that point, because that, like in the context of adolescence, this is what, it's really looking at an adolescent period, which is difficult in itself. And again, from age 10, that's why we separated it from early onset, because there are differences, and that's a good point that you bring up, as you're growing up a little bit. There's a little bit of more space between the parent and the child, and then exactly how you say, the feelings of guilt, but still that very close relationship. And thank you. Yeah.
Such an important point. I can think of my own experiences of having that, and parents just being absolutely shocked and then feeling so guilty. And, it's that whole thing. We don't look at my child in the same way. Any other comments, questions? I mean, really beautiful piece of research. 2 fantastic presentations so far. So thank you so much. Great session. Hey. Going to move on to our next rapid fives. Okay, they don't have to be so rapid, but we will wrap you up. You'll know when the 5 minutes is up. So our first presenter is Rachel De Cruz, who's going to come and talk to us about Ponseti, clubfoot.
Hi everyone, my name's Rachel. I'm a children's physio from County Durham and Darlington. My project was a service evaluation of the Talipes service in my trust, and my presentation is entitled That Needs Changing, Understanding Education and Barriers to Treatment for Parents of Children with Idiopathic CTEV. So congenital talipes equinovarus is a deformity of the foot, and it affects about 1 to 2 per 1,000 live births. The current gold standard is the Ponseti method, and this involves a series of serial castings that changed every week, and it's between 6 and 8 casts. They then require a small procedure called an Achilles tenotomy in most cases, and a further 3 weeks in cast. They are then need to go into a foot abduction brace, and they're in the foot abduction brace for 23 hours a day for the first 3 months, and then nighttime and nap times until the age of 5. So as you can see, it's a really intense treatment process. So it is really effective though, and about 90% have a really good initial correction rate, and there's excellent and good outcomes in 78% of people at 30 years follow-up. But despite its effectiveness, relapse still occurs in about 40% of feet, and the main reason for this is poor compliance with treatment. So as a result of this, this study aimed to explore parental education and barriers to treatment for children with idiopathic CTEV at the Talipes service at County Durham and Darlington, and to provide recommendations for service improvement. It was a qualitative study, and it consisted of semi-structured interviews and case note review. So the interviews were conducted face-to-face or via Teams, and they lasted about 30 to 40 minutes. Data was then gathered from the medical notes, and the interviews were transcribed and analysed using framework analysis with 2 other specialist physios also working with me. So there was a number of themes generated. I've just chosen to discuss the ones that were the most important in forming the recommendations. So the first theme identified was poor prior knowledge of the condition. 5 of the 6 parents had never heard of the term talipes before, and 4 out of the 6 had heard of clubfoot but weren't sure what it was. And all the parents felt that the terminology used at the time of diagnosis really impacted their understanding of the condition. One of the parents said, "So after the first scan, I was quite upset because I didn't know what it was, and they didn't say clubfoot, did they? Because I think I would have clicked then." Another thing that was identified was there was a lack of initial information at the time of diagnosis, whether that they were diagnosed antenatally or diagnosed at birth. So 5 out of the 6 parents reported that. And they also reported that speaking to a specialist when they first start treatment eased their anxiety. All of the parents also reported that all the information they were given was given verbally, and they felt that they struggled as a result of that because they couldn't remember what was said to them, especially with the having a child at the same time to raise. Parents, as a result of their lack of information, resorted to using online resources. And so 5 of the 6 parents did that. The one parent that didn't felt they were quite well supported, and they felt that the online resources varied in quality, and poor quality information caused anxiety. 3 out of the 6 parents also used online support groups, and they felt that this was really beneficial to air their concerns and to discuss the practicalities of raising a child with talipes. So one of the parents said, there were some lovely ones on the Facebook group, posting the children when they're 18 as athletes and things like that, and that it gives you hope. The last theme identified was the emotional toll on parents, with all parents reporting negative emotions like worry, anxiety, and feeling overwhelmed. They all expressed concerns about their child's future, and some of them even expressed judgment from the family and the public, with some finding that the family members thought the treatment was quite cruel. One of the parents felt that they had to keep it together for the sake of the child, and she said, "I didn't want to be worried all the time because I had a little baby to look after, and you just need to be okay." So as a result of the findings, we developed the following recommendations. A review of the terminology used with parents to make sure that we have understanding from the onset. Awareness amongst other health professionals like the sonographers and the maternity ward staff, to make sure that parents are given good quality information from the onset and signposted to good quality resources like the STEPS website. Antenatal counselling delivered by the specialist physiotherapist delivering the treatment, to ensure again that good quality information is provided from the onset and parents don't have that period of time where they are worrying and they have a lack of information. And the same with the physiotherapy presence on the maternity ward, again for the same reason, and to catch diagnosis early. Information provided verbally with leaflets and online, so that parents have the ability to look back on the information that they were given. Like I said, they struggle to remember what was said to them verbally sometimes, especially with the stress of having a newborn child. And local support groups, so that parents can meet people in their local area and have those discussions like the practicalities, like what car seat can I fit the boots and bars in and stuff like that. So in conclusion, this study found that a lack of information provided to the parents at the time of initial diagnosis caused significant worry and anxiety. Good quality information provided promptly may improve confidence and reduce anxiety. And that parents had a range of emotions throughout the treatment process, and that health professionals are in an excellent place to provide the support. Yes, thank you very much.
Excellent. Thank you so much, Rachel. I'm going to get you to take a seat because we're going to have another rapid fire, and then we'll have time for some questions. So we're lucky in this session. Right, this is now an opportunity now to call to the stage Kath Brimlow, who's going to come and talk to us about early interventions. Welcome, Kath.
Hi, yes, so I work in Scotland as a charity. We're a third sector, and we're looking at how does the accessibility for parents with children with neurodisabilities compare between weekday and weekend programs. So for many years we've run a weekday program, and this was just physiotherapy, and it was a single profession, so it's physiotherapy only. There was a fee charged for over 3-year-olds, and we had 17 children within that 18-month period between January 2018 and June 2019. And then obviously COVID happened, and we stopped the program. We saw children individually at that time, face-to-face or via Zoom. And then in 2022, we started a pilot Saturday early intervention program, which ran for 18 months, 3 half days per term. We run, so it's 3, either Saturday morning or Saturday afternoon, and it was siblings group as well. It was multi-professional. So it was physio, OT and speech and language therapy. There was no fee, it was free to parents, and we saw 34 children in that time. And the biggest kind of feedback we got was that the program was so accessible. That's what the parents said. It was accessible for the whole family. Grandparents were welcome, aunties, uncles. And the main measurement that we chose for measuring increased accessibility was from Michelle Phoenix's work from McMaster University. And that was both parents being able to attend the appointments together, or for one parent to be able to attend with a supportive adult. And we compared, in the middle you can see the demographic data, attendance data, postcode searches for SIMD and UR codes. And so results. So we did find that the accessibility was increased. So both parents or one parent with another supportive parent was 11% in the weekday and 66% at weekends. And we found that who attended the appointments, so if we look at the weekend program first, the bottom graph, you've got both parents, mum and gran, mum and auntie, and dad and grandparents. And at the weekday program, we only had 11%, and that was both parents or mum and gran. And as you can see, mothers attended the program more than anybody else. If we look, this was an unexpected result actually. We didn't expect this at all, but the UTA rates were much lower for the weekend program. They were still quite high because obviously we're talking about very complex children who are often very unwell. But if you look at the weekday program, so the bottom graph, child was unwell, reason was unknown, they didn't say, but there was holiday and another appointment or hospital admission. In January 2019 we had snow, so that stopped the program. Parents ill, housing issues, so that was parents waiting in for an electrician or plumber. Transport issues, we had problems with trains for a week, and also childcare issues as well, with the mum having to look after another sibling. Weekend program, they didn't tell us as much why they couldn't come, so that's 65% unknown, but child unwell or holiday, other family commitment, and that was kind of mums looking after grandparents. And then Botox or PEG after those procedures, they couldn't come. And which areas did we reach? So we looked at the Scottish Government 8-fold urban rural classification, and all the UK countries have that urban rural classification and the index of multiple deprivation as well. So as you can see with the weekend programme, we actually attracted more parents from rural areas, because obviously it was half a day, so they would travel down for 3 hours rather than just an hour and a half. And also, well, we're quite near IKEA, so I don't know if that was a draw as well. In our COVID, when we opened up a little bit, there was one family who did actually say that IKEA was also an attraction as well. And then the postcode, as you can see, just to remind you, the data zones 1 and 2 are the most deprived areas, and 9 and 10 are the least deprived areas. And the weekend programme did attract more families from the deprived areas than the weekday. So in conclusion, we did the weekend programme did increase more accessibility, and that was by 55% more parents or one parent with another supportive adult were able to attend. Lower UTA rate by 10%, 26% more families attended from rural areas, and we attracted families who lived in the most deprived SIMD data zones, which I think was because not necessarily it was a weekend programme, but because it was funded. So it was free, so they didn't have to chase any funding. We're aware of the small numbers, but we're considering our findings for future design of our EIP programmes. Obviously, weekends are potentially more expensive, but we have in our contracts that we work 10 Saturdays a year. So staff are used to working Saturdays. And thank you for listening.
Kath, come over and take a seat there. Thank you so much for that presentation. And well, have we got any questions now for these two speakers? Anna, come on.
Thank you. Thank you. Thank you so much for your presentations. They were both very, very interesting. And I just wanted to ask Rachel, please, if I may. And I apologize if I missed it somehow. So the title of your presentation was Understanding Parental Education. I had a feeling that there was a lot about lacking education. So that poses my question is, how did you find your sample? How did you choose your sample? And was that a focus, because you used the thematic analysis, was that the focus of the topic guide? Are we seeing just one perspective of parents who don't know? In Royal London Hospital, we have very diverse
So we only interviewed those with children under the age of 1, and we offered it to every child under the age of 1 that was under the Talipes service. So in total, I think there was 14, and we only ended up interviewing 6 parents. So 3 of them didn't attend when they were invited. 3 of them had safeguarding issues, and then I think another one had just refused. So we got the sample that we could with what we were able to. And the reason we did under 1s was because we wanted to have parents that were kind of fairly fresh into the treatment, so they kind of could recall what information they were given in the initial stages.
Yeah, and I suppose just picking up on that, was there something about the questioning as well? Was it that you were looking for lack of knowledge, or were you also looking for what was given?
The questions were quite open, so we just asked them what information. So we kind of went by it at each stage of, so if they were giving an antenatal diagnosis, what information did you receive at that time? And we just left it open to whatever they kind of information they could give us. And then again at birth, and again when they first came to physio. And so they kind of, it was just based on what they've told us. And to be fair, I forgot to read out my quote, but one of the parents has said, I really didn't get much information. In fact, I didn't get anything at all. That's why I found it so overwhelming. I didn't realize it was going to be a really big journey. So I think it was kind of the overarching theme, really, that parents just weren't really well informed at all going into the treatment.
I can see the Ponseti physios coming forward. I think Christine's got a question.
I realised I didn't introduce myself before. Sorry, Christine Douglas. I work at the Royal National Orthopaedic Hospital in Stanmore. So yeah, it's really, really great that you could demonstrate a need for antenatal counselling, and the BISCOS consensus also identified that need. So I think that's really helpful, isn't it, to petition the management teams. How did you design your kind of counselling session and your education leaflets?
Sorry. Actually, our recommendations haven't really come into play at the minute. The only thing we've worked on so far is creating a web page for our Talipes service that kind of will give video demonstrations of stuff like how to put on the boots and bars. We're kind of in the process of moving it over to orthopedics, so everything's kind of been, but eventually we would like to, we're kind of basing our information at the minute on what's available, like on the SEPS website, and directing parents towards that.
Great. And I think having a web presence as well on your trust website is so valuable for parents, isn't it? So that's great. Thank you.
Thank you. Any other questions?
Hi, Rachel again from Devon. Thank you so much for your presentations. My question's for Kath. Actually, it's more of a I thought your presentation was magical what you're offering. And, you know, having worked in schools in rural areas in Devon, I imagine the impact on families who are a little bit lost at weekends, what to do with their children in areas where there's not a huge amount of community support is really magical. So I just wondered whether there's any way of capturing beyond your amazing data around, you know, UTAs and aspects of who you kind of captured in your service. What's the feedback, both from families but also professionals? Did you manage to capture any of that?
Yeah, that was an abstract last year. This is like a trilogy. Yes, I know. It's like a trilogy. You have the next bit next year. Yeah, that's really nice. I mean, it was a parent questionnaire, parent satisfaction thing. So I know that they've got, well, from Jane's excellent teaching, I know that they're positively biased. But actually, yeah, the parents really, they really appreciate a group. That's the first thing, because they really appreciate the NHS physios. I mean, they really appreciated the expertise and the advice and everything. But what they miss is actually meeting other parents, because a lot of the NHS physios around in our area will do home visits. And that is so, you know, important and everything else. But they really miss meeting other parents. And I think everybody's fed up of online and Zoom. And they don't want to do that. They want to actually meet face to face. So that would seem to be very special. So they really appreciated that. The groups, some of them worked really well. Actually, I could spend about half an hour, so please stop me. Some of the groups worked really well because the parents were really open, and some of the groups didn't work so well because some parents were quite reserved and shy, and all the feelings that we're discussing, felt guilty, and you know, and everything else, had difficult, you know, they found the child very difficult with no sleep and communication difficulties, feeding difficulties, but they appreciated sharing advice to each other as well. They could use the facilities of our centre. So we've got the hydrotherapy pool, we've got Rebound, and because we had small numbers, we could tailor it to the child as well. So they really appreciated that. It was a parent programme, so it was parent mediation. So again, it's Michelle, Phoenix, and I've forgotten the other chap's name, the other guy's name, but it was a parent mediation. So we were teaching parents. So the NHS physios would give goals, and then we would ask the parents what were their goals, and then we would work with them to work on their goals. One criticism that we did have from the other abstract was we didn't communicate with the NHS physios because we just didn't have time. We didn't have time to find their contacts and everything else. So they enjoyed that as well. And one criticism was that there wasn't any time within the programme itself to talk to the parents. And we didn't introduce other parents, we introduced us, but we didn't introduce other parents. So we're looking at the weekend programme starting again, and we're going to have like an introduction to start with. That was a very long answer to your question, so I hope that's okay.
Okay, thank you. Got another question at the back. If you'd just like to introduce yourself and ask your question.
Thank you. Good afternoon. I'm Fiona Beckerleg, a paediatric physio, actually in Uganda. But just sort of following on from what you were saying, Kath, that what is the future plan for this weekend program? Is it, and what is the scope there to actually train parents up to be able to run the program going forward, so that because we know how much parents value that getting together, but when you want to be trying to get other people in into such a program like this, is the potential for that going forwards? I'd be really interested in the future.
We've looked, we kind of stopped the program and then looked, and we looked at, is this being recorded? It's being recorded.
Online, record to the online audience.
Okay. We've looked at other approaches. So we looked at EI Smart, but that costs £7,500 per member of staff for all the training that they mention. I don't know if it's a pick and mix or whether you actually have to do everything that they suggest. And it will take about 4 years as well. There's also GAIN, which is goal, activity, and movement enrichment, which is from CanChild. No, it's not. It's from Iona Novak and Catherine Morgan, but that's fortnightly visits, home visits, and we can't afford the travel. And also parents don't want that, they want the groups. So we're definitely looking at groups. And we have looked at parent and empowerment. And I think because of Scotland, we're looking at online. But CanChild are also doing this. They've got their Envisage program. So they've got, and that's research at the moment in Canada and Australia. They don't want any other groups, any services doing that, but they're looking at 5, I think, themes and 5 online programs with that. That is for their own Indigenous population. So we would be looking, I think it would need obviously cultural difference with that, yes. So we're looking at doing our own, and we're just at the moment putting together surveys, interview questions to question parents about what they want, because we might decide what they need, but it's what they want, it's their program. And yeah, it would be good to train parents to run this. We're looking at, we've got early years practitioners who are really good, so we're looking at them perhaps carrying this forwards. So we've got lots of ideas, so we're just kind of perhaps doing little pilots next year to see which one works the best, and maybe a collaborative approach. We've got a music therapist at the moment working with an OT, and they're doing 6 sessions for children, and that's working really well. That's really appreciated.
It sounds like you are a mountain of ideas and innovation, and amazing work. So look, I think we're going to round up our session. I don't think there's any other questions at the moment. We're going to round this session up. Firstly, just huge thank you to our first 2 speakers. Fantastic research. Absolutely thrilled to have that work. Over to this side, this is service evaluation, and that's a big flag up for that. So we've got researchers, we've got service evaluation. Everybody can get involved with research in some frame or way. So I think we've had a wonderful session this afternoon. Thank you so much for the time and effort that you've put into preparing your presentations, to the research and service evaluations that you've done. Please carry on the great work, and we're thrilled from the APCP's perspective to have you as part of our contribution to this conference. Thank you very much.